All right, let's talk about implantable cardioverter-defibrillators, or ICDs. If you're a medical trainee, you absolutely need to know the why, what, and how of these little devices. Why? Because they're one of the most powerful tools we have to stop sudden death in its tracks. So let's jump right in.
So, to really get why ICDs are such a big deal, you have to look at the numbers. And honestly, the main number is just staggering. In the US alone, we're talking about up to 400,000 people dying from sudden cardiac death every single year. Just let that sink in. That number right there is the reason this technology is so incredibly important.
Okay, first things first, we've got to clear something up that trips a lot of people up. Cardiac arrest is not the same as a heart attack. Here's the easiest way to think about it. A cardiac arrest is an electrical problem. The heart's wiring goes haywire and it just stops beating correctly. A heart attack, that's a plumbing problem, a blockage in an artery. Now, the two are related for sure. A plumbing problem can definitely cause an electrical problem, but they are fundamentally different events. So, here's how we're going to break it all down. First, we'll look a little closer at the problem of sudden cardiac death. Then we'll see exactly how these ICDs work. After that, we'll figure out which patients are the right candidates. We'll even walk through the implantation procedure. And finally, we'll cover what life is actually like for someone living with an ICD. All right, let's dive into the clinical challenge we're really up against here. You know, the scary thing about sudden cardiac death is that it's sudden. This isn't a slow decline. It's a sudden, catastrophic electrical failure. The most common culprit is a chaotic rhythm called ventricular fibrillation, or VF. That's when the heart's electrical signals just become a disorganized mess, and the heart quivers instead of pumping. And that's why, if this happens outside of a hospital, the survival rate is shockingly, tragically low, less than 10%. And that terrifying number, that's exactly why this technology is such a game changer. It's our way of putting a safety net right inside the patient. So, how do these things actually work? You gotta understand, modern ICDs are incredibly smart. They aren't just simple shock boxes. They actually have three main jobs. Job number one, obviously, is to stop those deadly fast rhythms. But they also act like a black box for the heart, constantly recording its electrical activity, which is super useful for us. And on top of all that, most of them can also act as a pacemaker if the heart rate gets too slow. Pretty amazing, right? So the device is smart. It doesn't just go for the big shock right away. It has a tiered response. The first thing it'll often try is something called anti-tachycardia pacing, or ATP. If the rhythm is fast but still organized, the ICD sends out a little burst of super fast pacing to try and gently nudge the heart back into a normal rhythm. And here's the crazy part. It's totally painless. The patient usually has no idea it even happened. But what if that gentle approach doesn't work? Well, the ICD knows to escalate. The next tool in its belt is cardioversion. This is a low-energy shock, and it's timed perfectly to the heartbeat to safely reset a more stubborn rhythm. Think of it as a slightly stronger nudge to get things back on track. And then, for the absolute worst-case scenario, for that chaotic, life-threatening rhythm like VF, the device unleashes its ultimate therapy, defibrillation. This is the big one, a powerful, high-energy shock that is designed to just hit reset on the heart's entire electrical system. And for patients who get this shock while they're awake, they almost all describe it the same way, like a sudden, powerful kick in the chest. Startling, for sure, but absolutely life-saving. Okay, so this therapy is obviously powerful, a real lifesaver. But that leads to the big question. Who actually gets one? How do we decide which patients are the right candidates? The reasons for getting an ICD basically fall into two big categories. The first one is called secondary prevention, and it's the one that just makes sense, right? A patient has already survived a cardiac arrest or a dangerous arrhythmia, so we put the device in to make sure it doesn't happen again. The other category is primary prevention. This is for patients who haven't had an event yet, but we know from their heart condition that they are at a super high risk for one in the future. Okay, let's get into the nitty-gritty here, because these are the numbers you really need to know as a trainee. The biggest factor we look at for primary prevention is the left ventricular ejection fraction, or LVEF. Basically, it's a measure of how well the heart is pumping. A low LVEF means a weak, scarred, and electrically unstable heart. So for patients whose heart muscle is weak because of a past heart attack, a key number to remember is an LVEF of 30% or less. For other types of weak hearts, the number is a little higher, 35% or less, but we also look for heart failure symptoms.
All right, we've identified the right patient. We know they need the device. Now, what actually happens during the procedure? Let's demystify it.
So the whole system really boils down to two main components. First, you've got the pulse generator. This is basically the brains and the battery of the operation, tucked into a small metal case. We place it in a little pocket under the skin in the upper chest, and the battery lasts for a good 8 to 12 years. Then you have the leads. These are thin, flexible, insulated wires that are the connection between the generator and the heart itself. They're what listen to the rhythm and deliver the therapy.
The procedure itself is pretty straightforward, and it really comes down to 4 main steps. Step 1, we make a small incision and create that pocket for the generator. Step 2, we guide the leads through a vein and carefully position them inside the heart. Step 3, we connect those leads to the generator and tuck it into the pocket. And finally, step 4, we test the system. We'll often induce a quick arrhythmia on purpose just to make 100% sure the device sees it and treats it correctly.
Now, this is super important to remember. Not all ICDs are the same. The classic one is the transvenous ICD, where the leads go through the veins and into the heart. This allows it to do all that smart pacing we talked about, but there's a newer option, the subcutaneous ICD, or SICD. With this one, nothing goes inside the heart or blood vessels at all. The big win there is avoiding vein and lead complications down the road. But the trade-off is that it can't provide that anti-tachycardia pacing, and the generator is a little bigger. Okay, so the procedure's done, the device is working. But that's not the end of the story, is it? What's life actually like with an ICD? This is the final and maybe the most important part of the whole puzzle. Because as amazing as these things are, let's be real, we're putting a sophisticated piece of electronics inside a person. There are always going to be potential risks, both right after the procedure and for years to come. You can kind of think about the complications in 2 buckets. First, you've got the surgical risks right around the time of the implant. Things like a collapsed lung, infection, or a lead moving out of place. Each of those has a low risk, around 1%. Then you have the long-term risks, things like getting an unnecessary shock or a lead wire breaking after years of flexing with the heartbeat. And that's why counseling your patient is probably one of the most important jobs you'll have. They need to understand that they have to come in for regular checks every few months. They need to know about driving restrictions, which are a big deal. They have to be careful around things with strong magnetic fields, like keeping their cell phone out of their breast pocket. And maybe the single most important point, you have to tell them that the ICD is a safety net. It's not a cure. It's there to save them when an arrhythmia happens. And this all leads us to one last really big question. This device is designed to pull someone back from the brink of sudden death. But what happens when that person is approaching the end of their life because of something else, like terminal cancer? The conversation about deactivating the shocking function is one of the most difficult and most important discussions in all of medicine. This is a conversation you will have in your career, and it's where technology, ethics, and true compassionate care all meet.